Thank you so much for the lovely introduction. I think that's just an eloquent way of saying that I'm a loudmouth in the name of public health. And also, it's not every day that we follow Dr. Jill Biden and that amazing background she had and me looking like I'm locked in a hotel room. So thank you all for joining us today to talk about this incredibly important topic. So here's how it goes. I'm a pediatric hospitalist. I see a variety of medical conditions, and there's one thing that's very clear. People want a diagnostic answer, and then they want a solution, especially when it comes to infectious disease. Well, here's a reality check. If we don't act more forcefully against antimicrobial resistance, this growing issue, we're in for some troubled times when it comes to treating children and adults with infections. And I'm very passionate about this topic. And more importantly, I and a lot of others are optimistic that we can tackle it. And that's why I'm honored to be moderating today's panel. Antimicrobial resistance, or AMR for short, is one of the greatest threats facing the well-being of the world's population. In fact, the World Health Organization called it one of the top 10 global public health threats facing humanity. That's wild. And if the present trends continue, by 2050, AMR will become a greater cause of mortality than heart disease or cancer. And so as the bacteria that cause infections become increasingly drug resistant, even common things like surgery, childbirth, chemotherapy will become increasingly life-threatening, and they already right now pose risks. So this is something that we have to be very awake in addressing, because it's not a theoretical future risk, it's already happening. In 2019, the CDC put out numbers showing that drug-resistant infections affected over 2.8 million patients annually, which was higher than what was previously believed. And so while the COVID-19 pandemic has got the world's attention and has become the focus, AMR continues to insidiously increase, threatening the lives of millions of people around the world each year. So much like COVID-19, AMR is a global issue that's going to require a concerted public health effort. And there's a lot we can do to slow it down. That's our focus for today. So with that, I'm just going to throw out a little icebreaker, very important thought starter question for all of our panelists. So, feel free just to tackle in order. We can start with you, Dr. Bertuzzi, but how has the COVID-19 pandemic impacted the problem of AMR?
Thank you, Dr. Patel, and good morning, everyone. Delighted to be here with you today. Well, you said it, you framed it perfectly, Dr. Patel, and I think starting from the fact that the AMR, the antimicrobial resistance, was among the top priorities, as you correctly said, for a public health and clinical microbiology agenda. So already a complex challenge. Now it needs to be addressed in the context of a global pandemic like COVID-19. What was a daunting task to start with, it has become, I think, even more daunting. In this context, I think we have some good news, and I'd like to start there. The good news is that probably increased hand hygiene that we learned during COVID-19, decreased international travel, decreased elective hospital procedure may actually reduce AMR pathogen selection and spread in a short run. So also much of the infrastructure that's being assembled right now, for example, the great program at CDC under the Advanced Molecular Diagnostic program of ramping up sequencing could be very helpful also for AMR in surveillance and treatment. But however, we also have bad news in the context of COVID-19 for AMR. It's the fact that antibiotics have been more widely used than before COVID-19. And that is worrisome because also, in conjunction with increased length of stay in hospital, for example, for conditions related to flu or so now they're much longer, those who are hospitalized. And with the overwhelmed healthcare system, unfortunately, like we have now, and the diversion of resources in surveillance and care, the drug resistance, antimicrobial resistance is becoming more of a challenge. And the data seem to be suggesting that. So it's getting worse, actually, with COVID-19. So I'd like to say in this context, make really two appeals to policymakers and policy analysts that can help shape the agenda. The first one is, we've been saying for a very, very long time that a pandemic was possible and could occur. And it found us very unprepared, as we all know. we've been saying that AMR is a great global threat. Let's not make all the community find itself again unprepared for this. That's really, we need to plan. That is very, very important. We need action. And the second appeal I have in this context is that AMR, just like COVID-19, are global threats. And so we need to have global plans. I think the nationalisms that we're seeing around the issue of COVID-19 are not helping the pandemic, and certainly will not help AMR, which is a global menace, not a national menace alone. So that, I think, is how AMR and COVID interact. And unfortunately, the balance may not be very good unless we act.
And Dr. Bertuzzi, thank you for kind of framing it in that way. I just want to ask if any of the other panelists have thoughts about how COVID-19 has impacted the issue of AMR. Dr. Ashley, for example, in your role in pharmacology, have you seen kind of a specific impact from the COVID-19 here?
Yeah, so although I am based at Duke, we actually help do antibiotic stewardship, appropriate antibiotic use in a network of hospitals throughout the southeast of the United States. And we have seen some pretty dramatic impacts. So the pharmacists and physicians with ID training have been largely diverted, up to 60% of their normal work to keep the antibiotics right size for their patients. And we know even with those efforts, about half the time antibiotic use was excessive. They have been completely diverted to take care of all these new drugs you're hearing about for COVID and deploying the COVID vaccines. And so we have left the shop unattended. But just like Dr. Bertuzzi said, a lot of these COVID patients are getting antibiotics. But the group is a little too busy to mind the store, so to speak. So we are seeing some devastating consequences in our antibiotic use in our hospitals.
Oh, sorry. I shouldn't be verbally sighing like that, but it just, optimism, remember optimism. Santiago, do you have thoughts about this?
Yeah, I think outside of sort of this general impacts on the science, I would say in Congress, it takes a very unfortunate crisis like COVID for there to be all eyes on just massive responses to how the government needed to respond. And so there's not really a crisis we've seen before where we spent trillions and trillions of dollars in response. And we had to do that because of the impacts of COVID on not just our healthcare system, but economics and education and just to name the issue. And so as we sort of address and talk about AMR, we are thinking a lot about how we need to take the lessons that we've learned and really think ahead of what that is. And so we do not want to come to a situation in a couple decades here where we are having to address crisis again further than the crisis that already exists. So that is the biggest thing that I think as we, you can see I'm currently in the Congress. I'm not wearing a mask, but I normally do. And so that it really has addressed every single sort of facet of our life here in Washington. And we do not want to face another issue like AMR where it will come to that again. So it really does impact every sort of aspect of our lives, and why it's really important that we're having this conversation today.
And Santiago, I'm glad you actually brought that up, the fact that it took a pandemic to get eyes on these things that are broken in our healthcare system. And God forbid, it's going to take an outbreak of a superbug to get people to talk about AMRs, which is why it's so important we have this conversation now. So thank you for bringing up that like startling comparison, but it's true. Amanda, what are folks at the Infectious Disease Society of America talking about regarding COVID-19 and AMR?
Well, thank you so much, Dr. Patel. So our members are infectious diseases physicians. For years, they've been on the front lines of the battle against AMR, and certainly they are the ones taking care of the sickest COVID-19 patients right now. And what we've seen, as Dr. Bertuzzi and others have alluded to, is an increase in multi-drug resistant infections. In fact, there was a pretty large study that was done over the course of several months over 2020, found a 24% increase in hospital onset drug resistant infections. And unfortunately, I think that wasn't a big surprise, because if you have a lot of seriously ill people who have to be hospitalized for a long time, especially if they have to be placed on a ventilator, of course they're at greater risk for these additional secondary infections. And the more we keep using antibiotics to treat them, the more and more resistant these bacteria are becoming. So to us, this really underscores why AMR is so central to our discussions about how to make sure we are better prepared for the next pandemic.
That's what it is. And last but definitely not least, because we're going to be talking about policy and how it relates to all of this, Dr. Lividas, first, correct me if I'm mispronouncing your last name. Could you share some of your thoughts as well about how COVID-19 has affected AMR?
No worries. There is a bit of a silver lining here, mainly diagnostics and data. But I think we saw from the very beginning of the response to the pandemic and through the power of researchers, we saw manufacturers, labs, and others step in to harness the power of diagnostics to very quickly respond, all the way from the lab setting and PCR that was used mostly for hospital-based care. But then we saw it go to the point of care and now to the home through over-the-counter tests. You know, we're really seeing the profile of diagnostics being raised as something that's mentioned at the dinner table. People are thinking about testing. They're thinking about it as a tool that can not only protect themselves, but also protect their loved ones for schools, before they go to work, before large events. So as we're thinking about, you know, raising the profile of diagnostics, which are so key to stewardship programs and part of the response here, that is one positive takeaway from the COVID pandemic. The other is data. And, you know, hopefully we'll talk about surveillance a little later in the panel, but we're seeing data updated daily for COVID. So we know that we can do it. The technology exists there, and there are definitely some takeaways there for our work on AMR.
And silver linings are things that we have to talk about when it comes to COVID-19. A lot of people out there have become like Google epidemiologists, for better or for worse. I think the lay public has been paying a lot more attention to data and getting a better understanding of how global infectious disease affects all of us. And we're actually one massive community. So on that note, kind of a framing question, which I'm going to toss to you, Dr. Bertuzzi, is could you just give us an idea of the size and the scope of AMR, and if we're actually seeing an increase in drug-resistant infections in the US? I mean, I kind of teased this in the introduction, but I'd love to hear you first kind of give an idea of the scope of how big this problem is. But then also, if you can give us a quick microbiology 101 of how exactly antimicrobial resistance occurs. Kind of a loaded question to start with.
It's an important one. Yeah, you said it in the beginning very appropriately. It's a big problem, really big in size and scope. I would say a daunting problem. And first of all, in the US, the most accurate data we have are from CDC, showing 2.8 million antibiotic resistant infections every year, taking the lives of 35,000 people. That's really a lot. And as you mentioned, Dr. Patel, if nothing happens, by 2050, we will have 10 million deaths globally and $100 trillion cost to the economy for this. Well, data at a global level are a little more difficult to gather with that precision. And the most accurate data we have are from WHO, from the Global Antimicrobial Resistance and New Surveillance System, or GLASS, which collects data from 70 countries. And it shows that we have 3 million laboratory confirmed bacterial infections. So to give you a sense, because the data are not comprehensive of the whole world, if you compare these latest data from GLASS to the one that we're collecting only in 2017, we see a sixfold increase on the number of infections reported. So it's growing, and it's very, very concerning. So from a microbiology perspective, well, the problem is really intrinsic in evolution. That's really what it comes down to. The little guys, the microbes, are very, very good at evolution. They do it much faster than other organisms, and they do it excellently. And Alexander Fleming, actually, when he discovered the first antibiotic, penicillin, immediately understood and reported that while as successful as antibiotics could be, that actually eventually they will not work because the microbes will outsmart the drugs. There are many, many ways that the microorganisms do that. But again, it really comes down to evolution. And I'd like to emphasize something that maybe not everybody appreciates immediately, is that antimicrobial resistance, while we always see as a health problem, actually at its core, antimicrobial resistance is an environmental problem. It's really something that happens in nature, given the nature of the microbes. We have found antimicrobial resistant genes in the mammoth, like way, way before antibiotics were in use. Actually, there's a very important environmental study in the rhizostome that looks at resistance genes in the environment. And this study showed a few years ago, showed that by taking random samples in the slums of Peru, so completely not exposed to selection through antibiotics, actually they identified over 1,000 genes that confer resistance, completely unknown before, and for which obviously we have no drugs. Think about it, just a random sampling in wild areas, in relatively wild areas, 1,000 genes for which we had no clue and to which there is no drugs. The medicine cabinet is empty. And these genes, we know, will travel in the environment and will reach, the whole world. And that's exactly right. I'll go back to what I was saying in the beginning. If we see this, that the pandemic of COVID-19, the havoc that has created a superbug, an antibiotic-resistant organism, could create as much havoc or even worse, precisely because it's all over in the environment around us. So that's why we need to plan. That's why we need action and coordination. And so there's some positive news. I'm very excited about some new drugs that are being developed. For example, a new area called immunoantibiotics. That's very, very interesting because these are drugs that are still very experimental, but they, besides attacking the microbe itself and killing it, which, as we know, tends to generate resistance very quickly because the microbe can outsmart the drug in very different ways, these new drugs actually have the capability of acting on the immune systems in specific pathways that are specific for their response to that organism, the isoprenoid pathway. And that, generates a response from the immune system. So you get your immune system to fight the microbe. So you recruit your own immune system and you don't rely just on the drug itself. Still very experimental, but that's very interesting. And many other areas as well. So we really need to research America, and it's an imperative. This is really, really important because the crisis is here and the scope is very, very large. And again, it's in the environment, and this will come to haunt us as humans.
And well, thank you for laying that out, Dr. Bertuzzi. And it's kind of what we tell people about the Delta variant. The Delta variant for this SARS-CoV-2 wants us to fail, because the virus wants to evolve and propagate. In the same way, Staphylococcus, Streptococcus, Enterococcus, Mycoplasma, Pseudomonas, and these bugs also want to continue to propagate and find mechanisms to defeat us. So I'm tired of using the war analogy for everything in public health, but that in many ways, it feels like an intellectual battle we're facing right now. Dr. Ashley, I want to toss a question over to you and talk a little bit about hospitals and contributing to and being able to address AMR. Now, previously, when we look at data, infections related to hospital stays and procedures are among some of the most serious drug-resistant infections out there. And, I'm curious about what the data has looked like or what has been happening during the COVID-19 pandemic, especially with so many patients being hospitalized, a lot of procedures, intubations, which you mentioned earlier, have been happening. Because on one end, I could see the COVID-19 pandemic with regards to all the procedures contributing to AMR, but on the other hand, I'm like, well, maybe because people were masked and there was so much PPE and hand washing, it wasn't a big issue. But Dr. Ashley, enlighten us.
Yeah, it's a great question. And it's one, honestly, we've all been trying to answer. And we just got some great data out of the CDC at the end of August. So there are several hospital-acquired infections that the CDC tracks regularly. And so they were able to take a look at the data through 2020. And it's kind of what we feared. There was a lot more use of ventilators. You probably saw on the news, how ventilators were in short supply in some parts of the country and the world. And overall in the United States hospitals, the use of ventilators in these patients went up by 25 to a little over 30%. So we had a lot more patients on ventilators, and that causes a risk for pneumonia. So we did see increases in those events. We also track bloodstream infections that come from having an IV line in, which all of these COVID patients had, multiple. They were requiring many drugs just for support, fluids, et cetera, heart support. And so as a result, we did see an increase in those line-related infections that we track, about 20% of those. Or up to 50% of those, and about 20% of our urinary tract infections from patients who had to have a urinary catheter in place. So we know that during COVID, because of all the things we were having to do, it's hard to really quantify what it was like in the hospitals at this time. There were shortages of some of the common PPE that we were used to using, so that we were using different PPE, different types of lines and things. And we know that when we do that, that carries risk for infection. So we have seen more infections. Amanda mentioned earlier, many of these were multi-drug resistant, as we do tend to see in our hospitals. So something we're following very closely. We don't have more recent data from 2021, but there is a little bit of a silver lining here. One of the infections we track is diarrhea caused by antibiotics, C. difficile. You may have been hearing about this recently. And it looks like, perhaps we think because of all this great hand washing and the types of antibiotics we were being used, is at least flat and maybe a little decreased during the COVID pandemic. So not entirely bad news, but still the numbers aren't where we want them yet.
And we've been asking healthcare professionals, please wash your hands. And it took a pandemic to get everyone to actually finally do it. And so, yes, that is a byproduct of the pandemic. And hopefully we'll see less C. diff, which I think I've been practicing medicine long enough to be able to finally sniff out C. diff versus other forms of diarrhea. And I've been smelling less of it. So I agree with you, Dr. Ashley. Dr. Levitas, am I saying your last name correctly?
It's Levitas.
Levitas. That's why I had to clarify. So Dr. Levitas, I want to ask you this question. I'm sincerely curious here. The federal government in the last couple of years, as a condition to participate in Medicare, started to require that hospitals have an antibiotic stewardship program, which is paramount to addressing this. So Dr. Levitas, could you tell us about the elements of an antibiotic stewardship program? What goes into it? How do people get involved with it? And is it actually having an impact? Is this rule by the federal government making a difference?
Yeah, sure. So we saw that rule come out in October of 2019, and I think there was a lot of hope at that point. But of course, that was right before the pandemic kind of started. And as we heard from Dr. Ashley previously and from others, a lot of resources were then pivoted away. Pharmacists who had been focused on stewardship programs were now pivoting to COVID, and it was all hands on deck for COVID. So though I was previously a hospital pharmacist and no longer there on the front lines, I can't imagine that we've really been able to keep up with those stewardship programs as much as we could have been had it not been for the pandemic. CMS also has kind of relaxed the requirements from hospitals and providers in light of all of the new requirements for COVID. So we have, seen a little bit of a delay there. We'll get more into the PASTOR Act, I'm hoping, and hear more from Santiago. But one of the elements in that bill is $500 million for stewardship programs. So hopefully we can get back on board there. And I really think Dr. Ashley, being on the front lines, will be able to speak to those requirements on the conditions of participation and get it from her firsthand.
I don't know if I'm frozen or if Dr. Levitas is frozen.
Not frozen for me. I can jump in real quick and just talk about the stewardship programs.
Please, yeah.
Yeah, so they follow the CDC's core elements for antimicrobial stewardship, and it requires very specific things be in place. So you have to have leadership support. That is absolutely essential, and that's been shown time and again. strong senior hospital leadership. And I will say, as a steward, something that's been great recently is people are coming to us and asking us about antibiotic use in the hospital. And that's certainly a new trend. So it is getting that attention. But you also need to have expertise in using the antibiotics correctly. So physician and pharmacist, co-leaders of the program, you need strong support from your microbiology group as well. We couldn't do this without the correct diagnostics. And so together we deploy the diagnostics in a way that makes sense to get patients on the correct drug as fast as possible. Also, antibiotics are unique in that they're really one of the few classes of drugs that everyone in the hospital uses. There's no place you can go and fail to find antibiotics in some way, shape, or form. So it requires a lot of education to the providers throughout your facility, and really customizing what your stewardship program does for the types of patients that you see. You know, maybe you're a big orthopedic hospital and you need to have plans there for how to prevent infections in your surgery patients by using antibiotics, and then also how to treat infections if they do occur. That might not be true for everywhere, for example, based on the specific specialties your facility provides. And then you need a way to measure your antibiotic use, which is real important. And I think one of the struggles people have talked about, and I think we're going to talk a little bit later during this panel, but measuring and tracking your antibiotic use and being able to give that feedback to providers as well so they can see how they're doing. Those have all been great leaps forward in the past several years, but we know we have some more work to do. We have seen the CDC does track how many of these core elements are in place in our hospitals, and they've seen a great increase with a few regulatory agencies such as the Joint Commission taking some time and attention towards stewardship, but also that condition of participation really catapulted it forward.
It's important to know. And I kind of want to chime in with an audience question for you, Dr. Ashley. Yeah. And on that note, if anyone has any questions, please feel free to just throw them in the chat box, and we will do our absolute best to incorporate them. But, somebody asked in the audience, like, how do we ensure that there is access to antibiotic stewardship and these AMR practices across the board, and they just don't exacerbate health inequities? And I think this kind of parlays into the next question I'm going to ask the panel in general, but like, how do we just make sure that every program out there actually does have AMR? Because I can't imagine that, smaller clinics or maybe some smaller community centers will have the same resources and staff needed to run a successful program as, say, large academic center. So how do we address that, Dr. Ashley?
Yeah, there are lots of creative strategies to do this. There are collaboratives where you can get expertise from one of the big academic centers, or maybe somewhere in your health system that will allow you to disseminate information to the local level. In our network here that we run through Duke, we see providers of every type involved in leading stewardship. Nurses, very important in the stewardship efforts. We have lots of places in emergency departments where the nurses really lead the charge for ensuring appropriate antibiotic use. A lot of our nurse practitioners and physician's assistants also take a keen interest here and can be leaders and champions. Our colleagues in infection prevention often do it because we know that a lot of our hospitals don't necessarily have a full-time infectious diseases physician available to them to do this. And similarly, may not have an infectious diseases trained pharmacist. So there are lots of ways to bring in the expertise from the outside in a collaborative nature, but still make sure, the bread and butter of using antibiotics, making sure we're not giving them too long, making sure we're using the most narrow drug we possibly can to treat an infection. If patients don't end up having an infection, but we thought they did, that's okay, but we need to stop their antibiotics. Those are things that we can really teach to a lot of different people, as long as there's some core leadership, making sure that the ship is still a sail.
So the core leadership and having people available to do this, I agree with you, Dr. Ashley, very important in making sure we're addressing inequity. But now, moving on and talking about diagnostics, and I'm going to toss this question back to you, Dr. Libidas, and to Dr. Bertuzzi, if you want to chime in, is about the role diagnostic tests play in addressing AMR, and if they can be better deployed by hospitals or clinics, because I can imagine you may have someone or a clinic out there who's got the tools, the know-it-all, and the forthright nature to say, like, we need to address AMR, but they may not have the right diagnostic tools. Is that a big issue happening right now?
Definitely excited about the future of diagnostics here. And we know that they are the bread and butter for guiding treatment. We've heard Dr. Ashley talk about it and how they can actually be used to make sure patients are started or not started in the event of a viral infection on the right treatment. And then there are other tools for susceptibility and resistance. And I think what we're excited about at BD is seeing diagnostics go from the point of care to the home setting as well. But when we think about the point of care, how much treatment could we actually do outside of the hospital setting in the community? And we're starting to see tests for resistance that are at the point of care. So I think it's harnessing those capabilities. We also know that diagnostics are the basis, and those results are the basis of surveillance, which can then help us continue to monitor trends and be able to respond at a much broader level to make sure that we are doing the right thing. And Dr. Bertuzzi, I'd be curious to hear your thoughts as well.
Thank you, Dr. Levat. I think you hit the nail on the head here, and it was said before. There was a very important word that was said by Dr. Ashley. We want to use the narrow possible antibiotic. And that's really true. That's good stewardship. Now the problem is, what antibiotic do we use, right, in order to treat that disease? And that's where diagnostics, become so important. Because if we have really fast and accurate way of determining what the pathogen is and what the resistance that pathogen shows, we can avoid using broad spectrum antibiotic and really hone in on the antibiotic that actually works. And that is really, really important for stewardship. So that's why diagnostics is so crucial to stewardship, and so crucial to use and to success, and for patients in treating patients. So really, really crucial argument here. And I would say that it's also you were asking Dr. Patel before, what can we do for effective stewardship? I think that if I can tackle this from a research perspective and a clinical microbiology perspective, I would argue that it is very, very important to develop good studies that also look at the effectiveness and cost effectiveness studies, patient outcome studies for diagnostics, because they're not as common as in other areas like in therapeutics, but they're really, really essential. Because if the clinical microbiology in the hospital, which is in charge of running the diagnostics to inform treatment, does not have reimbursement and payment for diagnostics that actually work and are effective to beneficial to the patient, we will not get there. And this is very important because the clinical microbiology lab has been radically transformed exactly by antimicrobial resistance. Always used to joke, saying that in the hospital, the clinical microbiology used to be the last door at the end of the hallway to the right. First of all, because it stinks, and second, the cost of running a test in microbiology lab is streaking a plate. It was $2 a test. Now, with antimicrobial resistance, we can't rely on this. We have very sophisticated testing, which costs about, for a respiratory panel, for example, that tests 25 different pathogens at the time, you go over $175 or so. So the question becomes, what is cost effective? What is important? What benefits the patients? And these are all studies that health economists need to do in conjunction with microbiologists and public health people, because we need to get really to some very, very effective and rapid diagnostics that can help inform treatment. Otherwise, we won't be able to treat as we should, and resistance will grow.
And, on the note about diagnostics and, how many tests are out there and what we're really doing, we do have to make sure that they're not only accurate, but there's some conservation among the tests as well. And there's a regulatory body. And Santiago, I want to jump to you because I believe you're working on the VALID Act with the FDA, which many people like myself didn't even know existed until today. So please enlighten us.
Yeah, I think it is important here to just highlight that diagnostics are incredibly important. And one of the things that I always think about, the silver lining, I think, as Dr. Lovatis talked about earlier of this pandemic, was that people actually know what a diagnostic test is and sort of can identify that. And they've been able to do that over the past year and a half. Senator Bennett, who I get to work for, has been working on a regulatory pathway for diagnostics for many, many years. And one of the biggest challenges 5 years ago or longer when they sort of started this was that no one really knew that diagnostics was a thing, and that it mainly also wasn't really regulated by the FDA. You know, we want to have diagnostics here that actually work, that are analytically and clinically valid, that, you know, you don't want to go and get a test and just say, oh, it works 50% of the time, so we're going to flip the coin. And if, you know, at one point it works in this situation, at one point it doesn't, and then we're going to give antibiotics or give a certain treatment based on that isn't the best way to go about the best standard of care for patients. You know, that's not the best way to go about that. And many people are actually very surprised when they find out that there is not a specific pathway, and that developers actually can choose to go through a device pathway to get there, similar to a device pathway to get the FDA to approve their product. And so we think that that's an important aspect of this as well, because we want to make sure that if there is a product that's being used to determine what type of treatment, to determine sort of what level of treatment someone is getting, that it's accurate. And it's just a really simple public health issue that we want to make sure that the FDA has the ability to come in. You know, many of you might remember during COVID, there were a whole lot of tests that were brought into the market that applied for emergency use authorizations. And I'm not going to get the number exact because I'm not going to remember, but it was over 250, that's for sure. And if you went through the FDA's website and you started to sort of look through those products, you know, there were generally a lot of random people who were trying to bring tests onto the market. People really came out of left field saying they wanted to help. And in many cases, and in some really important cases, you know, they did bring tests to the market that were helpful. But in a lot of cases as well, these were tests that didn't actually work. And so I think, you know, it's important as we talk about the really important use of diagnostics, which are incredibly important to address AMR. We also want to make sure that those tests are accurate and that it's not just, you know, anybody who's you know, has a centrifuge and some different things to be able to come in and say, oh, I have a test and I, you know, make sure it works. So that's an important aspect of this. And it's something that Senator Bennett has worked a lot originally with Senator Hatch, and then is now working on it with the ranking member of the Health Committee, Senator Burr. And so as we sort of move forward, that we believe that's a really important aspect to this issue as well, is to make sure that we have accurate tests on the market.
So Santiago, basically you're saying if I get a centrifuge off Amazon and I try to make my own test, it may not fly. Is that what you're spitting at me right now, sir?
if you get some data that you've collected, you can certainly send it to the FDA. They'll definitely tell you to take it off. I'm not questioning your ability to do this, but you know, that is sort of, if someone wants to take the initiative to do that, that certainly could happen.
And then that's why we're glad that there's some type of government oversight here, because I do remember seeing reports based on, you know, COVID-19 tests with like a 40% sensitivity. And I'm like, whoa, we're extrapolating here. Amanda, I want to turn to you because I want to talk about the federal-wide National Action Plan, which was launched to address AMR in 2014. Could you give us an overview of that plan then? But then also, you know, after the government reissued, or I should say released a second National Action Plan in 2020, if you could tell us what was changed in those 6 years and what kind of impact the plan is having.
Absolutely. So the plan sought to be very comprehensive, recognizing that AMR is a complex issue and there's not going to be one single silver bullet. We need to prevent infections and prevent the development of resistance. We need better surveillance, not only in human health, but in animal health and agricultural settings. We need to be investing in diagnostics, as we've been talking about. We also need to be investing in new antibiotics and novel therapies for multi-drug resistant infections. And lastly, we need global coordination because, as we've discussed, AMR, like any other infectious disease, does not respect national borders and really needs to be addressed at the global level. So there were goals and objectives around each of those different areas. I think one of the most important things that the initial national strategy did was to really drive Congress to deliver new funding to the tune of about $300 million of new funding in 2016 to really begin building up our national infrastructure to address AMR. So thanks to that first strategy and the funding that it helped to catalyze, we have better surveillance. We have the requirements for stewardship programs at hospitals and long-term care facilities, as we've talked about. And we've had increased funding to support research to better understand resistance and to help develop new tools to address it. And I think the plan that was released last fall really just continues to build upon the progress that we've seen since 2014 and really demonstrates the federal government's continued commitment to AMR. But that said, despite that progress, we've still seen some really persistent gaps. Our surveillance, while much improved, still doesn't provide us with the comprehensive real-time picture that healthcare professionals need in order to really anticipate and try to get ahead of the resistance threats to be able to really prepare for and respond to them in an optimal way. And I think a lot of that is because after that initial bolus of funding in 2016, things kind of leveled off and we really haven't been continuing to build on that infrastructure in the way that we need to. We've talked about the requirement for hospitals and long-term care facilities to have stewardship programs, and that's an outstanding requirement. And there is a tremendous amount of evidence that demonstrates that stewardship programs do improve patient outcomes, reduce inappropriate antibiotic use, and reduce resistance. But now we need to back up that requirement with resources. We really need, particularly for our smaller hospitals and other smaller facilities, resources to make sure that they can bring in the expertise and the personnel necessary to really do stewardship well. We also have seen that the objectives associated with funding early stage antibiotic R&D have been successful in delivering some new antibiotics and in helping some smaller companies to really come in and fill the void that was left when most large pharmaceutical companies left antibiotic R&D. But unfortunately, those small companies that have been responsible for the bulk of that innovation are now struggling to stay in business because it's really hard to earn any kind of a return on an investment on new antibiotics when a brand new antibiotic is launched and all of our clinicians appropriately say, don't use it unless we absolutely have to because we have to protect its effectiveness. So we really need a much more creative approach to revitalizing our antibiotic pipeline. I think that's one of the key things that's missing from our national strategy. And it's why it's so important that we fill in these gaps with legislation to create some of the new initiatives that we know are needed to have a comprehensive AMR response. I think the last thing I would say that we truly need is people. We need experts on the ground to take care of the patients who are at risk of and who contract resistant infections. We need people to lead our stewardship programs. We need people to run our clinical trials. But we can't get enough physicians to specialize in infectious diseases because it's one of the lowest paid specialties and physicians have enormous amounts of debts coming out of medical school. So it's really critical, I think, on so many different levels that we really not only maintain, but intensify our national focus on AMR.
Oh, I lit up the minute you said debt. I'm like, hey, I have $200,000 of debt. Love to get rid of that one day if someone wants to talk after the session. I joke. So, Amanda, it's almost like you set up what I wanted to ask Dr. Livadas. And we got an audience question coming in, and I'm going to combine these two for you. I think I mispronounced your last name again. I apologize. Livadas. Did I say it correctly?
Livadas.
Okay, you know what? It's never going to happen again. We're doing this in real time. Livadas. So Dr. Livadas, I wanted to ask you how digital technologies can assist with surveillance to track AMR, we also got an audience question, which I think we can turn into a compounded question for you. And it's, what is the evidence that antibiotics are being used appropriately? So Amanda just talked to us about kind of like federal oversight and legislation, but is there, aside from the digital technology question, is there a tracking method that we look to see if an antibiotic is being inappropriately prescribed in a certain area? Is there some type of report form? I don't mean to say that we should be whistleblowing on, you know, colleagues, but is there some way to monitor that? Because I do feel like, you know, every now and then we will hear stories of an inappropriately prescribed antibiotic for whatever reason. So sorry about the two-part question, but I think they're both really important. And I think you're the person to ask.
No worries. I'll start with the question on data and technologies first. So BD does have software that has the capability to aggregate infection-related data. It provides us insights for about 15 to 20% of the US population. So as Amanda mentioned, you know, we definitely don't have all of the surveillance measures in place, and there are more resources needed to be able to implement that kind of software throughout all US hospitals and to really cover the whole population. But we are making some progress. And this software specifically allows us to get some proactive information on treatment, but then of course informs the broader surveillance trends as well. And when we think about AMR as a global problem, you know, we definitely need to put the surveillance and the technologies in place to be able to have this information at a global level. So BD is doing some work with the Fleming Fund to help fill in some of those gaps. For example, in Kenya, there are only 5 labs that are actually reporting to GLASS, and we compare that to over 40,000 in the US and almost 20,000 in Germany. Same thing in Uganda, I believe there are 2. You know, we need to work to increase the ability to measure and report AMR metrics across the entire world, and to make sure that the information that the WHO is gathering is correct as well, and the most up to date. In regards to the second question about how do we make sure we're tracking, you know, using that kind of software, you are able to kind of get into what the patient looked like and understand what they were eventually treated with. And I believe it would be up to each hospital to kind of then take action to do a postmortem. But Dr. Ashley might have some thoughts about that as well, and how it kind of works on the front lines.
Oh, Dr. Ashley, if you do, please share, because, you know, oftentimes it does come down to exactly what Dr. Lovatis just mentioned, is these like M&M conferences in the hospital. And I was trying to go backwards and pinpoint when it happened, which seems very labor intensive. But is there another way to kind of track, I should say, inappropriate or inaccurate prescribing?
Yeah, there's a lot of work going on in this field. So in the outpatient area, because every time you go to the doctor, should you be prescribed an antibiotic, there's a diagnosis code associated with it. So there are some, what we call the low-hanging fruit in stewardship. So there are people who actively track, you know, if you're getting an antibiotic for a viral infection, for example. So that should never work. You should never need that. And so we call those never events, and we do track those pretty routinely, because we can, through combining the prescription and the billing data for outpatient visits. In the hospital, it gets a little bit more difficult. There is certainly a time when we're treating a patient where the clinical workup is going on. And so we don't necessarily know yet. I mean, we're getting better with all those diagnostics we've discussed, where sometimes we can tell earlier, but it can take a day or two sometimes to figure out exactly what might be causing disease in a patient. It may or may not be an infection. Those do tend to be a little bit more hospital-based discussions, because there are hospitals who use different antibiotics in different ways, you know, and there are different resistance patterns in different hospitals. The hospital that's right across the street from where I am has a different resistance pattern than we do here. And that's just the way it is. It's why we have to use the data from our lab to design regimens that are best for the patients that we take care of. And I saw somebody asked here about, you know, sort of, you know, who's to blame for the resistance problem. And I think a fundamental principle of antibiotic stewardship is that nobody gets up to misuse antibiotics. The problem is how we use antibiotics changes. And what we were all taught, what I was taught in pharmacy school, you know, 2 weeks of antibiotics used to be good enough. And we've learned that that's no longer what we really needed to do. And so there's just a ton of education that needs to happen. And that's what happens a lot in the inpatient setting, is there's a discussion over what is the correct duration, what is the right drug. So it can be fairly labor intensive, although our colleagues, particularly at the VA, are getting really good at using the computer-based data to look back at it and see how we're doing.
I think that's really important. And it's important that we, as providers, also take a vested interest in this area. And, you know, we're going back and forth between what politicians are doing and what healthcare professionals are doing, which I think is making this talk very fun. And on that note, Santiago, could you tell us how and why Senator Michael Bennet became interested in AMR, which I think is awesome, by the way?
Yeah. So, you know, Senator Bennet has long been a champion of trying to figure out how do we get just better therapies onto the market, and has long focused on different aspects, whether it's childhood cancer or in this case, AMR. And about, I guess at this point, 5 or 6 years ago, he worked on a bill again with Senator Hatch called the PATH Act, and then which sort of in ways made sure that FDA had the tools to sort of help expedite approval and work with developers to get more antibiotics on the market. And over the years has just been sort of working on different types of things. And, you know, a few years ago, you know, AMR sort of started to come up again more. We were starting to hear about it more. And then the pandemic hit, COVID-19 happened. And one of the things that we try and do in this, in my role here, is take a look at, okay, what are the immediate crisis needs? What are the things that we're going to need to do now? Let's look at what we need in the next few years, and let's look at what we need in the long term, and kind of approach policy in that way. And as we interacted with whether it was smaller biotech firms in our state, in the state of Colorado, which has a really amazing biotech industry, they're doing really amazing things, or you know, just chatting with different people, you know, including Amanda, had many conversations about this, you know, sort of understood that the issue of antibiotics and the issues in the antibiotic marketplace were slightly different, that we weren't going to just be able to use what we call around here push incentives, which is, you know, front loading money to develop different types of therapeutics. That's certainly important. That is certainly something that we need to continue to do. I think that is demonstrated by things like having the technology for the COVID vaccine ready to go. And that's how we were able to get the actual COVID vaccine ready and approved in, I think, less than a year. And so that's certainly still important, but with AMR, you know, this is a challenge that is, we don't have the technology ready to go. There are certainly things like Dr. Bertuzzi mentioned, there are things in the pipeline, but others have mentioned that sometimes the things that go in the pipeline actually make it all the way through FDA approval. And because of the way that the market is set up, they will have to go out of business. So they've spent millions and millions of dollars trying to get this product to the market, and they get there and the market can't sustain them. And so, you know, we really were trying to figure out, how do we fix this issue? How do we make sure that we can address this? And the fact of the matter is, when there's something like a market failure like that, the government just has to step in, because there was not going to be a way for venture capitalists to sort of step in here. It wasn't going to be worth it for them to get the return on investment. And so, you know, we sort of stumbled, I guess, upon the idea of a subscription model, which is something that individuals in the UK had been working on. A lot of academics had sort of proposed. When Senator Bennet sort of learned about this, a subscription model, which, if you think about it in simple terms, is, you know, it's sort of like Netflix, but the federal government pays for a product, and maybe there's a month that you watch Netflix, maybe there's a month that you don't. But at the end of the day, you're still paying for the product and you're getting as much of it as you need. And so it's sort of, that's the structure of what this looks like. And what it does is it allows those companies to have a certainty in their return on investment. And so Senator Bennett, as we sort of tried to propose different ideas and what that looked like for a solution, his background has some background in finance, and really made sense to him that this was the best way to move forward and sort of build on the work that he has sort of done. It's great that the FDA has the tools to do these things, but if those products aren't able to come onto the market later and stay on the market, then all of that work is really for nothing. And so thinking about that, and then in the context of COVID, and thinking about future crises, it sort of made sense, and that's how we landed on this, and really believe it's the best solution forward.
Well, I love that we are talking about ways that politicians are actually now getting involved in the right way in public health, which we've seen that back and forth during the pandemic. So kudos to Senator Bennett for taking the charge there. Amanda, before we jump into more of the other questions, could you just quickly tell us what the PASTEUR Act is and how it's going to help combat AMR generally? And obviously, Santiago, please chime in as well if you see fit. We have about 7 minutes left, but I think we can get through the rest of the question set.
Absolutely. So the bill really fundamentally changes the way that the federal government will pay for the most critically needed, truly novel antibiotics. So basically, instead of paying for the volume of antibiotics used, under PASTEUR, the federal government would be able to pay for the true value that these antibiotics bring to our society, regardless of the volume used. So again, for antibiotics that are truly novel, that address unmet needs, that are really critically needed to address AMR, the federal government would be able to enter into contracts with the companies that develop these drugs, and through those contracts, pay set fees for the supply of those antibiotics, regardless of how much or how little those antibiotics are ultimately used. So many experts believe that this is truly the approach that's needed to revitalize and maintain our antibiotic pipeline in a sustainable way. And it really aligns very well with stewardship because it removes any sort of financial pressure to overuse antibiotics. The other thing that the bill does that I think is incredibly exciting is it creates a new stream of funding to support hospital stewardship programs with a real priority on the hospitals that need it most, the critical access hospitals, safety net hospitals, rural hospitals. We've talked so much throughout this panel about how these hospitals really need resources to get their stewardship programs to be as robust as they need to be for all of those patients to benefit from them. So, I think the bill really tries to have this great balanced approach between strengthening the pipeline and making sure the drugs are used appropriately.
Thank you for sharing that. And I love the fact that it's called the PASTEUR Act, science nerd alert. I want to go to you, Dr. Ashley, Dr. Lovatis, and I'm going to once again combine a question with some audience questions. On the outpatient side, a 2018 CDC report estimated that at least 30% of antibiotic prescriptions during that year were unnecessary for whatever reason. And, Dr. Lovatis, I think you mentioned earlier some things that we're going to be doing in terms of provider education, just to kind of ensure that antibiotics only being used as needed. But I was hoping you both could comment on why you think 30% were not used appropriately or were not necessary, but also what can patients do to address this issue as well? Because I think that's an important component here. Perhaps we can start with you, Dr. Ashley.
Yeah, I'll start with what patients can do. I think anytime when you're with your prescriber and you're being assessed, if they're going to start an antibiotic, ask why and ask if it's really needed. I mean, we do that when we take our own kids to the doctor now. Do we really think this is needed? Or what would be a sign that I no longer need this antibiotic? To really engage, because there are a lot of consequences of antibiotics. They have side effects. They obviously promote resistance. And then there's some more direct side effects that patients experience themselves. So I think that's very important. Now, the reasons behind why 30% of that antibiotic use might be unnecessary are complicated. There's actually a whole body of research that tries to look at this, and lots of people have theories. You know, if you talk to some providers, they'll say, well, the patients will come in and really want to have an antibiotic. Historically, there were rules at daycares and things that would require you to give an antibiotic to a child to get them back into care so the parents could go back to work. So those parents would come, you know, begging for their antibiotics. But unfortunately, a lot of education has occurred and a lot of those policies are changing. But we continue to learn more and more about why it is that antibiotics are given even when a viral infection is suspected, which doesn't need an antibiotic at all. So lots of different reasons, but I'll see if Rita has any additional thoughts or has seen anything interesting.
Well, I think that no one can really argue the need for provider education, and I'll kind of stress the funding aspect of it, and something that we were so glad to see in the Pasteur Act on funding stewardship, to really make sure that as those novel antibiotics are brought to the market, that we're using them appropriately, and we're not seeing resistance to those novel antibiotics as well. I've been out of practice for a while, so I actually didn't know about the recommendation for the shorter course of treatment that Dr. Ashley mentioned. But, no matter who you are, that need to fund those programs and to have robust provider education is key.
And, I'm all about the provider education, and I hope that we have a little bit more mainstream conversations. And that even nowadays means in social media, whatever outlets young people are looking at when we talk about appropriate use of antibiotics. We mentioned this earlier before the panel about how people can get over-the-counter antibiotics in other countries. I mean, how many times have people heard of backpacker say like, oh, pack some Cipro, and if you get diarrhea, just take a couple pills. Like, we just have to completely change the culture of lackadaisical antibiotic use. This is a comment I want to read. I have a feeling that this is going to resonate with some of our panelists here. A comment we just got earlier is, I want to acknowledge an audience comment noting that CLIA, which Clinical Laboratory Improvement Amendments, provides oversight of diagnostics, and the issue of diagnostic regulation is so complex, we could have a whole panel on this topic alone. I agree. And I think each component of this is extremely complex. As we wrap up, and I just want to ask a quick question to every member of the panel right now, and then we'll take a couple quick audience questions after that. And everyone we can just go in order and all answering this question, because I think it's important and it'll be interesting to get different perspectives. AMR is a global health threat, and it requires participation from countries from all over the world, and different countries have different access to resources and technology. So what role should the US play globally in this fight? And since Dr. Bertuzzi, do you want to start with that one? What role should we be playing in the United States?
Thank you for this question. One word: leadership. That is absolutely essential. ASM, we have a large global health program, and we are pivoting a lot of those resources toward antimicrobial resistance to do exactly what was discussed, try to help collect data, create infrastructure, but there is leadership. There's a big need of leadership, not flag planting, but really coordination, leadership working together. I think those are really the words that resonate with me.
Amanda, I'm going down the line.
I think Dr. Bertuzzi really hit the nail on the head. I was thinking leadership as well. And, in some ways, the US has long been a leader in the global fight against AMR. We were one of the first countries to develop and fund a national action plan. But we can't rest on our laurels. We need to really advance that leadership even more. We need to do more funding, particularly for low and middle income countries, to help them build up their surveillance systems and their stewardship programs. Earlier this year, the US and our G7 partners made commitments around strengthening the antibiotic pipeline and promoting appropriate use of antibiotics. But now we need to really fulfill those commitments by, passing legislation like the Pasteur Act and really kind of putting our money behind the claims and the verbal commitments that we make so that they have real meaning.
Santiago, where are we at as the US in addressing this globally?
I think I'll just echo in part what Amanda and Dr. Bertuzzi have said. I think it's really important that the United States understand that people are looking at this country to know how to address this and to take a leadership role here. I think it's really important to mention that AMR was addressed not just in the health ministers meeting at the G7, but in the Treasury ministers meeting at the G7, and is a really important aspect of funding these things. And I am really excited that the administration and their drug pricing policy that the Biden administration and their drug pricing plan that they put out last week mentioned that they want to see legislation passed to foster this type of innovation and develop new novel drugs through a delinked model like in the Pasteur Act. And so to continue working on that, and I think Senator Bennett is very happy to be working with his colleague from Indiana, Senator Todd Young, who has been just an incredible partner, as well as colleagues, Representatives Doyle and Ferguson in the House of Representatives. And I think, it's a small crew of four, but mighty in that, we're trying to really push this effort forward. And that's important at a global level, because it's not just us that are impacted by that. Agreed.
And Dr. Lovatis has that like pensive hand gesture, like she's ready to pounce and say something here. So I'm curious about what's on your mind.
I'm excited that we've talked about the Pasteur Act, and I just do think that we are playing a leadership role here throughout through potentially passing this legislation. I think even though we've seen the subscription model in the UK, the strong focus on stewardship in the Pasteur Act is really what makes that difference to make sure we are using those novel antibiotics appropriately. And then as part of that, surveillance and diagnostics as well, and definitely rapid diagnostics that can make the course of treatment easier for providers, and hopefully have more treatment on the outpatient setting, reducing HAIs and making it more streamlined for patients.
Thank you. Thank you. And Dr. Ashley, please drop the mic for us.
Well, I think, obviously leadership, as everyone has mentioned, is important, but I think to be very specific, we need to lead in the surveillance as well as the treatments. One of the big problems we had at the beginning of the COVID pandemic is we couldn't necessarily diagnose it in everyone. And AMR is somewhat similar. There are resistance mechanisms out there today that we haven't quite figured out how to diagnose yet. And so we need to lead both at looking for what those resistant pathogens are. Just like COVID, AMR travels the globe, and we need to be out there looking for it, as well as finding creative ways to treat it further on down the line once patients do get infected. So lots of work to be done, but lots of great people to collaborate with to get it done too.
And that's the important part, is that there are a lot of great people. And we know that with superbugs or with viruses, outbreaks globally are outbreaks everywhere, and these things are just a flight away. So with that, I just want to thank all our panelists so much for your time and your insight. Thank everyone out there. We are literally out of time right now. In the last 30 seconds, I just want to tell everyone to stay optimistic and make sure you're sharing good, accurate information. There's a question from the audience, and it's saying, with the ubiquity of Google searches, how do we ensure we're sharing the most accurate information within our communities? Always check the sources and make sure that you are paying attention to what you are reading and you trust it and it's valid before you click share or retweet. And AMR is such an important problem that I hope everyone continues to stay engaged here. And with that, I bid everyone farewell, thank you, and stay curious.